Okay, so I am going to video me studying for my pharm class because hopefully this will help me. And if you're watching this for some reason, I hope it helps you. If you hear, I have a heater on because it's cold outside, and I have a sign behind my head that says "You are my sunshine," so I'm just going to move that. So the first thing that we're going to talk about is anemia. There are different type of drugs that you can take for anemia. Iron is one of them. So anemia can happen. There's different ways, but if you have maturation defect anemia, then that could be a reason why you would need to take an iron supplement. So here we have ferrous sulfate, ferric gluconate, and iron dextrin. Those are 3 different types of iron that you can take for anemia. With these different drugs, you can have nausea and vomiting, diarrhea, constipation, stomach cramps. It's very hard on the stomach, so you're going to experience black or tarry poop. You're going to also possibly have discolored teeth or eyes. If you do have an iron supplement that you take orally, you're going to want to take it with a straw to help prevent the discoloration of teeth. It's absorbed better with ascorbic acid, which is found in vitamin, like orange juice and vitamin C types of juices. And it's worse with antacids and calcium, so you're not going to want to take iron with milk. It's contraindicated in people who have ulcerative colitis, peptic ulcer disease, gastritis, esophagitis, hemolytic anemia, which is sickle cell anemia, and cirrhosis of the liver. You're going to want to assess red blood cell count, hemoglobin, and hematocrit counts before you administer iron, as well as assess iron levels in those patients. These are just nursing implications, so like with orange juice or water, not with milk or antacids. Take it with fluid, preferably not with food, but since it is hard on the stomach, a lot of people do take iron with food. You're going to want to avoid milk or antacids 1 to 2 hours before and after taking iron. You're going to dilute liquid, and you're going to take it with a straw, so that is for those oral irons, ferrous sulfate and ferric gluconate. You sit upright for 30 minutes afterwards because you want to make sure that it gets down the esophagus. You warn your patients about black or tarry stools, and you don't want to overcook vegetables. So the antidote for iron is deferoxamine, and I'll probably say these words wrong, but that's how you spell it. It binds to the iron, and it helps get it out of the body. So if somebody has an iron overload or an overdose or whatever, you give them that, and it's the antidote for that. So now over here to folic acid. Folic acid is highly needed for pregnant women because it helps decrease the risk of neural tube defects in the unborn baby. It helps with the formation of red blood cells, so erythropoiesis, and DNA and RNA synthesis. It is a water-soluble vitamin, and it's absorbed in the small intestine, specifically in the upper duodenum. You can get it from dietary sources include dried beans, peas, oranges, and green vegetables. You should not use folic acid until the actual cause of anemia is determined because it may mask symptoms of other types of anemia, such as pernicious anemia. Speaking of pernicious anemia occurs when there is a deficiency in intrinsic factor, which is something that's produced by the stomach. The cells that line the stomach create intrinsic factor. And in order for intrinsic factor to be like activated in the body, you need to have vitamin B12. Vitamin B12 over here, cyanobalamin, however you say it. The patient lacks intrinsic factor, the glycoprotein that's produced in the stomach lining. So we need to pay attention to patients who have had stomach issues. So if they've had a gastric bypass or stomach cancer or gastric sleeve or any other types of issues where their stomach may be affected, they are likely to be deficient in intrinsic factor. This medicine, cyanobalamin, is given IM. It's viscous and it's painful, so that's something you're going to want to warn your patients about. Look how beautiful my hair is. I washed it this morning. It's dry. It's just gone everywhere. So those are the different types of anemia drugs. The next thing that we're going to talk about is women's health. So, we got lots of stuff on here. So the first thing we're going to talk about is estrogens. So estrogen is needed in women's health, obviously, and it's primarily dealing with ovulation. So, bam, we have conjugated estrogens, which are oral. We have estradiol transdermal, obviously transdermal, that's a patch. Estradiol cypionate, which is a shot, and estradiol vaginal, which is a cream. So these are the different brand names: Coumarin, Climera, Depo estradiol, and Estrance. Those are the different drug names that you would find, like if you saw commercials or whatever. These are the generic names, the big names. So these are for contraception. They're also for menopausal hot flashes, osteoporosis, and breast or prostate cancer. They're contraindicated in estrogen-dependent cancer. So if there's a cancer that like thrives on estrogen, you're obviously not going to give an estrogen shot, cream, dermal patch, or pill to these patients. It's also contraindicated in pregnancy and active thromboembolic disorders. So, ooh, look at that hair. Oh, that's so pretty. So there are interactions. So if the patient is taking anticoagulant like warfarin, there's going to be decreased oral anticoagulant. It's going to be toxic with tricyclic antidepressants, and smoking is going to increase clot risk. So you're going to want to check the history of drugs for your patient to see if they have any blood thinners or blood anticoagulants. Check to see if they're taking any antidepressants, and you have to check to see if they are smokers. Its adverse effects include a thromboembolic event, so it's the most serious. It's like a blood clot in their body that could like break off and move to like their lungs or their head. Nausea is the most common. You can also have photosensitivity, so you want to encourage your patients to wear sunscreen. And chloasma is darkening patches of skin. Specifically, you'll see this on the cheeks. Nursing implication is that the smallest dose is primarily given first to see if it can relieve the symptoms. It increases the risk of endometrial hyperplasia, which is a precursor to endometrial cancer. So those endometrial cells that line the uterus will increase, like there'll be a higher number of them. And it's not for those with a history of endometrial cancer, obviously, or a history of breast cancer. So I'm going to grab a tissue real quick. Ooh, it's cold outside. Okay, the next thing we're going to talk about is osteoporosis. Maybe this will help you. I don't know if it's going to turn backwards or what. There's osteoporosis. So there's different types of drugs that you can take for this. Osteoporosis happens when somebody has low bone mass. It increases the fracture risk. So my grandmother, Dee Dee, did not drink a lot of milk when she was little because she hated the taste of it. And so she was prone to having osteoporosis. So they call it holy bone disease, so that instead of her bone being solid like this, it had a bunch of little holes all throughout it. So it was weaker. So those that are at risk for osteoporosis include women, Caucasian or Asian descent. Dee Dee was Caucasian. She's not Asian. Slender body build, definitely Dee Dee. Those who have estrogen deficiencies. I don't know if Dee Dee had that. She might have. Who knows? Smokers. She wasn't a smoker, but good to know. Don't smoke. Those who have a high alcohol consumption. I don't know if Dee Dee had that or not. Low calcium intake. There we go. Dee Dee did not like to drink milk, so she definitely had a low calcium intake. Those who have a sedentary lifestyle or a family history. I highly doubt that we would consider Dee Dee's lifestyle a sedentary because she is a pretty active woman, but she may have had a family history considering I have pre-osteoporosis, so maybe it's genetic. I don't know, but I don't know. She had osteoporosis, but she's in heaven now, so it's all good. So there's 3 different types of drugs that one can take for osteoporosis, 2 different categories. So biphosphonates and SERMs. Biphosphonates include alendronate and risdronate. They both end in dronate. This one's Fosamax and Actinol. They inhibit osteoclast-mediated bone reabsorption, and they enhance bone mineral density. So they're preventing bone material from being reabsorbed by the body, like taking that calcium out of the body and into the blood, and it's helping bones maintain their density. So those are 2 ways that it can help bones maintain their strength. Ralphoxine is a Vistra, and that's a SERM. That's a simulated estrogen receptor on bone and increasing bone density. So with biphosphonates, the adverse effects include headache, GI upset, joint pain. Say it with me, esophageal burns. Esophageal burns occur when the patient takes the pill and it gets like stuck in their esophagus. So since this pill, I don't know, just destroys things or whatever, it's going to destroy that very soft tissue in the esophagus and it's going to burn it. So we first of all have to encourage our patients to sit up or stand when they take this pill and to drink it with like a full glass of water. So esophageal burns with biphosphonates. You want your patients to stand or sit up when they have this and drink it with a full glass of water. There's also a risk of osteoporosis of the jaw, bone, joint, muscle pain, and low energy fractures. It interacts with calcium supplements and antacids, so you're going to want to take biphosphonates 1 to 2 hours apart from antacids and calcium supplements. Aspirin and other NSAIDs can cause GI issues while taking biphosphonates. It's contraindicated in those who have hypocalcemia, which is low calcium levels. Kind of makes sense. And esophageal dysfunction. Again, esophageal burns. If their esophagus isn't going to work because they have esophageal dysfunction, they can't take this drug because they can get esophageal burn. With SERMs, ralfloxacin, Evista, there's no R there, but Evista, it's got adverse effects of hot flashes, leg cramps, increased venous thromboembolism, which we'll go back to. It's teratogenic for women that are pregnant, so people who are pregnant cannot take this drug. And it's also got an adverse effect of leukopenia. So your patient, you have to check their white blood cell count before they take this drug. It's contraindicated in pregnancy. Remember, teratogenic. And it's also contraindicated in patients who have a venous thromboembolic history, DVT, or PE. Why? Because it increases the risk of blood clots. So if somebody has the history of thromboembolism, a PE, pulmonary embolism, or a DVT, deep vein thrombosis, there's an increased risk of these blood clots with taking a SERM. So a nursing implication for this is that the patient has to stop taking SERMs 72 hours before prolonged immobility. So if they know they're going to be taking a flight like across the ocean that's going to be for a really long time, or they're going to be sitting for a really long time, they cannot take this drug 3 days beforehand because of that increased risk of clots. The next drug class that we're going to talk about, still within women's health, is progestins. Progestins include levonorgestrel, which is also commonly known as Plan B, and medroxyprogesterone, which is Provera or Depo-Provera, which is a shot. So Plan B is emergency contraception, so it's taken within 72 hours of unprotected sex, or endometriosis and hypermenorrhea treatment. So if somebody has endometriosis or a really active, overblown period or whatever, they can take this drug with that. Depo-Provera, inhibits the secretion of pituitary gonadotropin, which prevents ovulation. This is a contraception. While this is an emergency contraception that would be taken like 3 days after sex, this one is like maintenance. It's kind of like you get a shot once every 3 months. It's anti-neoplastic action against endometrial cancer. It's long acting. Remember, it's a shot that patients can get once every 3 months. And it's given IM, so they can have it taken in the butt, which sounds really weird to say you have it taken in the butt, but I'm not posting this video, so it's okay. And there's also an increased risk for bone loss. So the nursing implications for this include that you want to give them the smallest dose possible, needed to like show effects. You want the patient to take this drug the same time every single day. So it's kind of a weird way to say that because the shot's going to be given once every 3 months, and Plan B is like an emergency contraception. So they're not going to be taking Plan B every single day anyway, but that's what the notes say. So let's not focus on that. With a meal, you're going to take this drug with a meal to decrease GI upset. If there's a patch of this drug, you do not place on the breast or the chest area. There's an increased risk of sunburn, so the patient needs to wear SPF. And annual exams like breast exams or pap smears are totally encouraged, which, I mean, they're encouraged with everything, so I don't know why we have this, but they are. Contraceptions. Triphasic oral is the most closely duplicated level of the female cycle. So they say that Depo-Provera is a triphasic oral, which I'm kind of making that up right now, but it kind of makes sense because it's going to stay in your body for such a long time that maybe it does mimic what you're supposed to be having. There are adverse effects: hypertension, edema, thromboembolism, which is like pulmonary embolism, myocardial infarction, and a stroke, alterations in lipid and carb metabolism, and increased serum hormone concentration. These drugs are also having interactions with oral contraceptions. That's not a sentence that makes sense. These drugs, when taken with things, have decreased contraceptive actions. So if you're taking this and you take an antibiotic or a barbiturate or seizure drugs, TB drugs, isoniazid or rifampin, I don't know how to say these words, there's going to be a decreased level of contraceptive protection. So if you're taking an antibiotic and you happen to be on Depo-Provera, you need to have a second form of birth control, whether it's a condom or whatever. There's a decreased effectiveness of the drug because you're taking oral contraceptive. So if you're taking a beta blocker, you're at a greater risk for high blood pressure because this drug is winning and the beta blocker is not getting to your body. If you're taking warfarin, there's going to be a greater risk of blood clots because you're taking this drug is winning, the warfarin's not. Tricyclic antidepressants are the same. Vitamins, hypnotics, anticonvulsants, theophylline, and antidiabetics. Those drugs are going to lose because this is the bigger gun. Get it? He's going to win. They're going to lose. He's going to lose. The antibiotic's going to win. The barbiturate's going to win. The seizure TB drug's going to win. So you have to use another form of contraception. Now we're going to talk about men's health. Not as complicated because men's bodies aren't that complicated compared to women. So these are androgen inhibitors. They inhibit the enzyme which converts testosterone to DHT, which would normally stimulate prostate growth. The result of this is a decrease in prostate size. So the prostate is a gland that surrounds the urethra in a man, and the urethra is sending urine from the bladder to the outside world. So if that if that gland is swollen, if it's increased in size, the urethra is going to have a harder time getting urine to go through. So think of it like a donut. Here's your donut. This is your not your prostate. If you're a man, this is the prostate. The urethra goes through here. Let's get something to make a urethra. Here's the urethra. It's a ruler. The urethra is going through the donut, which is the prostate. If the prostate is increased in size, which you're going to have to just bear with me, like, oh, it's getting bigger. It's going to squeeze on this little tube that's going through it. So it's going to have a harder time of urine going through it to the outside world. So the goal of these drugs is to decrease the size of the prostate to allow the tube, the urethra, to let urine go through. Does that make sense? I hope it does. I wish I had a donut and like a tube to show you, but this is as best as we're going to get. So, drugs over here. Finasteride is called Proscar. This drug reduces the size of the prostate. There's a disease called benign prostate hyperplasia where the prostate just grows in size. The growing in the size of the prostate puts more pressure on the urethra, so urine has a harder time going through the urethra. So this drug is going to reduce prostate size, but it takes about 3 to 6 months for it to occur. So you do need to tell your patient, like, hey, you're not going to see results immediately, but it's going to take time to do it. This drug is teratogenic. That means women cannot touch this drug. Finasteride, women cannot touch this drug. Teratogenic. It can cause defects in the unborn baby. So women, if they are giving this drug to a man, need to have the proper PPE on in order to handle it. I'm going to turn my space heater off because it's blowing right on my legs. In the same family of androgen inhibitors, we have minoxidil, which is commonly known as Rogaine. A side effect, which is not a harmful side effect, sometimes it's a wanted side effect of finasteride, is hair growth. So they took this drug, and it's pretty much in the same class, and they're like, hey, if it can grow hair, why not we try to market it to women as well? So they, like, I don't know what they did. They did something, and it's now this drug down here is safe for women to handle as well. It's Rogaine, it's topical. Women can put it on their head and then grow hair just like men. So the adverse effects of these drugs is that it can cause a loss of libido or erection, ejaculatory dysfunction, gynecomastia in males, where it's breast development in males, myopathy, which is muscle pain, hypotension, so a decrease in blood pressure, dizziness and drowsiness. Nursing implication is that these drugs can be taken orally without regards to meals, and you need to protect them from light and heat. You need to assess urination patterns because obviously that's what you're trying to better here. You're trying to help the patient be able to go to the restroom and not have to like strain as much, although they're not pooping. Allow them to void easier. That's a fun word to say. You're also going to want to assess sexual function because they are going to be losing loss of libido and erection. And you're also going to assess prostate size and their serum. Prostate serum, I don't know what that A stands for, PSA, but it has something to do with their prostate. I don't know. We'll look it up later. PSA. Okay. So those drugs specifically shrink the prostate. Androgen inhibitors. Over here, we have alpha-1 adrenergic blockers. These drugs immediately shrink the prostate. So while these drugs do shrink the prostate, they take about 3 to 6 months. These drugs do it immediately. So immediate prostate shrinkage, this can also be used for post-op urinary retention in men and women. So remember, ProScar over here, that is teratogenic to women. Women can't touch it because it can cause defects in the unborn baby. There's a drug over here, women can take it. Even though they don't have a prostate, it can help them with post-op urinary retention. The drug over here is tamsulosin, which is called Flomax, which is quite a funny name for a drug that helps people go to the bathroom. The adverse effects include tachycardia, hypotension, syncope, depression, drowsiness, impotence, urinary frequency, which that's the goal here, is to make them pee, dyspnea, and visual changes. This drug, you're also going to want to assess urination patterns, sexual function, prostate size, and serum PSA. Again, we don't know what PSA stands for, but you're going to assess for it. It's got like prostate serum. I don't know. Who knows? So now we're going to get to phosphodiesterase inhibitors. Who knows how to say these words? I don't. These treat erectile dysfunction. You've probably seen commercials online for Cialis or Viagra. Those are phosphodiesterase inhibitors. They treat erectile dysfunction by allowing the buildup of cyclic guanosine monophosphate. It relaxes smooth muscle and permits the inflow of blood. Guess where it's going to permit the inflow of blood? You got it right, into the penis. So these drug names end in a fill. So a friend of mine said that men are trying to get a fill from a lady, but I told her, I was like, no. These drugs are filling the penis with blood and cyclic guanosine monophosphate. So they allow them to get an erection because it's treating erectile dysfunction. With sildenafil, which I don't know how to say it, but it's Viagra, your patient cannot take it with nitrates because there's a risk for severe hypotension. If they have a prolonged erection, which is called priapism, that's an emergency and they need to go to the doctor immediately. And they take that drug 1 hour before sex. With tadalafil, which is Cialis, it can also treat benign prostatic hyperplasia. The adverse effects of these drugs are headaches, flushing, heartburn, priapism, remember the prolonged erection for more than 4 hours that they need to go to the doctor for, and unexplained visual loss. It's contraindicated in patients who take nitrates, which is Viagra, and the nursing implication is that those over 65 have reduced clearance so that they have a greater risk of toxicity. Okay, I'm going to take a quick break and then I'll be right back.